Today we're going to look at the abdominal examination. When you start off with the abdominal examination, it is very important to first start off by doing a general examination of the patient. In that way you can determine a lot of pathology that might be seen in the general examination. So start off by first of all just examining your patient's eyes to look for any jaundice. In other words, there might be liver pathology causing jaundice in the patient and you might pick it up in that way. Look for anemia as well, pale conjunctiva in the patient. The patient can stick out his tongue. Can you stick out your tongue for me? That's fine, thank you. And then also basically, while the patient sticks out his tongue, look for any signs of cyanosis. The next step would be to look for clubbing on the patient's fingers, which might also detect liver disease in the patient that you are going to examine the abdomen of, as well as edema that you might have to go down to the patient's legs, which will also show any intra-abdominal pathology, or it might show intra-abdominal pathology. The next thing would be to actually go and feel for any lymphadenopathy in the patient. So what you can do is, by starting off, is to just feel the patient's neck from the top down. Make sure that when you feel the patient's neck, or when you examine the patient's neck for lymph nodes, make sure to basically feel between the two heads of the sternocleidomastoid muscle and see if you can detect a virtuotracean node in that area, which will show lymphatic spread of any intra-abdominal malignancy. The stress, if the patient can lie down in a 15-degree angle on a flat hard surface and the patient can breathe easily, usually there's no distress that the patient experiences at the time. Okay. What I'm going to show you is how to examine the patient's abdomen. Basically, if you suspect that there might be any pathology inside the patient's abdomen. And the abdominal examination makes it difficult in the sense that there's a lot of organs packed inside the abdomen. They all lie closely together. Various pathological processes might affect the organs inside the abdomen. So you need to have a good idea about the anatomical site of the organ, as well as how to actually go and feel for that organ and to clinically detect if there's any pathology present there. A patient is best examined if they are lying flat on a fairly hard surface, with the head end of the bed raised around about 15 degrees, so that you open up the area between your pubic symphysis and your xiphisternum, so that you can basically feel for all the organs in a directed way. First of all, you usually start off by just asking your patient if they experience any pain somewhere. Do you have any pain anywhere, sir, that you can tell? On the left hand side. Right. If your patient voices the fact that they've got pain somewhere, be wary that you don't press too hard there when you do your initial examination, because they might have severe pain and you can actually hurt the patient when you examine them. When you start off your examination, first what we will usually do is inspection, like we would start off with any other examination. So first of all, inspect the abdomen. Look at any scars that you might find on the abdomen, any midline scars, signs of previous surgeries. Look at any areas where you will maybe see masses that you can determine. The best way to see a mass on the patient's abdomen is actually when you use natural light to detect a subtle shadow that the mass will then basically throw on the side of the abdomen. Second of all, look at your flanks on the sides. Patients that might present with ascites or fluid inside the abdomen might have very full flanks that hangs down to the sides of the bed. On your inspection as well, look for any obvious reasons. Always remember that your inguinal examination to detect any areas of or any occurrences of inguinal hernias is also important in your abdominal examination, and should always be done, as well as a rectal examination when you go to your palpation point. Then also look for the color and any scratch marks maybe on the abdomen, which might give you an idea about pruritus in the patient's condition. You can see on this patient's abdomen, you don't see any scars or anything that looks abnormal on the patient's abdomen. Next, you would go to palpation. First of all, we always stand on the right side of the patient's bed when we examine. If you are right-handed, you usually start in the left iliac fossa, move all the way around to the right iliac fossa. Okay. Just make sure that you always palpate all 9 quadrants on the patient's abdomen to make sure if you don't feel any, or the patient doesn't experience any tenderness, or you don't miss any masses in those areas. So what we would then basically do is to start off with a light touch. So we would actually lightly touch the patient's abdomen in all 9 quadrants. We know that he's got pain in his left upper quadrant, so we gently touch there. Can you feel any pain? If I touch lightly like this, you don't feel any pain. So basically then you go to all 9 quadrants and you just slightly feel for slight pain or tenderness that the patient might experience. Right. Next of all, you would then basically do a deeper palpation to see if you can detect any masses that you might miss on your superficial palpation, as well as elicit any further tenderness that you might feel. So in the same way, we're going to start from the left iliac fossa now with our left hand. So I'm just going to press a little bit deeper now. So just tell me if you experience any pain. All right. So then you basically go and you feel a little bit deeper. The flank area, a little bit tender. Yeah, and your left.
Yeah,
so it's tender there. Yes. Right. With the gastric area, not so much. Periumbilical area, that's all right.
A little bit.
Suprapubic, nothing there. So when you palpate deeper on the abdominal examination, you might feel deeper lying masses in the abdomen, which will then guide you towards basically the possible pathology that you might find there. If you feel a mass, the mass should be described basically, first of all, as the presence of a mass. Secondly, the size, the shape, the consistency, the edges, as well as if it's mobile or not, and even if there's a pulsation in the mass or not. If you've done your deeper palpation and you do not suspect anything, you can go to the area to see if the patient has got peritonism, if you suspect any peritonism in the patient's abdomen. Make sure that you explain well to the patient beforehand what you are going to do. You are going to press over the area that's tender and you're going to release your hand quickly. Okay. If the patient experiences a sharp type of pain in that area, that would be a positive test for peritonism. So what I'm going to do now is I'm going to press down where your tenderness is, and then I'm going to let go. So don't be frightened by my hand. Right. Okay, so if I press here, you said it was a bit tender. If I let go, do you feel anything?
Yes, it feels
Do you feel a sharp type of pain? Okay. If I press over this other area, you feel the pain?
mm-hmm.
If I let go?
Yes.
Okay, so you feel a sharp pain.
That's good.
It's possible that you might experience peritonism in this patient. So it's actually irritation of the peritoneum overlying that certain organ that you are examining. After your palpation, basically the next thing that you need to do is to go and feel for specific organs. So we need to feel for the liver, for the spleen, for the kidneys. Those are the ones that you will usually feel on an abdominal examination clinically. The way that we examine for a liver would be to basically put your hand flat on the side of the patient's abdomen, just below the umbilicus in the right side, the right midclavicular line, and you would then basically keep your hand there and ask the patient to breathe in deeply. That's fine, thank you. If you feel a bump against your hand, it means that the liver is moving down early with respiration, and then you basically feel the edge of the liver bumping against your hand. If you don't feel anything there, you can move your hand slightly up. Just inspire again for me. Thank you. And this you continue. Inspiration again. Thank you. And again. This you continue all the way up towards the costal margin so that you can feel the edge of the liver. The edge might be round, it might be sharp, it might be nodular. There's different ways of determining the edge of the liver. This would also be the way to feel for a palpable gallbladder in a jaundiced patient. If you start with your liver examination from the costal margin and move downwards, you might miss the edge of the liver and you might actually miss hepatomegaly in the patient. The way the spleen enlarges is basically from the lateral aspect on the left-hand side in the left upper quadrant, all the way obliquely down across the umbilicus to the right iliac fossa. So the way you examine the spleen is basically the same as for a liver. You start in the right iliac fossa and ask the patient to breathe in deeply, just below the level of the umbilicus. Again, nothing there, again. Sorry. Remember not to press hard in this area because the patient experiences pain there. If you think that you might be feeling the tip of a spleen, it can help to basically put your left hand behind the patient's lower ribs on the tip of the 10th rib. Press the area forward and then again feel under the rib cage for the tip of the spleen. If the spleen is slightly enlarged, you will feel the tip of the spleen pressing down on your fingers as the patient inhales. Another part of the splenic examination is if you want to confirm that you feel an enlarged spleen, you can always feel superior medially for the notch of the spleen. That's indicative of splenomegaly. Remember, in children, the spleen will enlarge down the flank on the left-hand side towards the left iliac fossa. So the examination for a large spleen in a child will be exactly the same as for a liver in an adult. To feel for any enlargement or pathology in your kidneys, first of all, what you can do is to put your left hand in the patient's small of his back, between the rib cage and the part of the pelvis at the back, between the bony prominences. Put your right hand over the left flank area, and then while you're pressing down there, you can either feel this ballotting between your hands. In other words, when you push down, you will feel the kidney bumping against your hand at the back. If you can also ask the patient to breathe in deeply. If they breathe in deeply, you can sometimes feel the lower pole of the kidney bumping against your hand. On the right hand side, it's exactly the same, but you just change your hands around. Your left hand goes behind the patient's back, and your right hand basically in the right flank area. Sometimes you can't feel the kidney. If it's small, you might feel it if it is lower down in the patient or if it is enlarged. But if you don't feel a kidney in the patient, then usually it is there's no pathology in the kidney on that side. After you've felt for your different organs, the next step would then be to basically percuss the abdomen to decide if there's any distension of air or if the abdomen is percussing normally. So exactly the same way, you start off on your left iliac fossa and you start to percuss the patient's abdomen. Some areas, like especially over the bladder, if it's enlarged, might be dull. The rest of the abdomen will be hyperresonant to percussion or resonant. Always make sure that you also percuss over a mass if you feel a mass, to make sure that the mass is in fact dull if you percuss over it. You also need at this stage to detect if the patient has got ascites. Ascites in the abdomen will move with the patient. So basically what you can do is there's two types of tests that we can do. The first one is to do a fluid thrill. Ask for assistance from somebody else or ask the patient to basically just hold the hand in the middle. Okay, certainly maybe just hold your hand like this for me. Okay. Put your left hand on the other side of the patient's abdomen and then gently tap on the one side. Thank you. A fluid thrill would be elicited basically through the fluid, and you would feel the vibration of the throw on the other side when you do this. The second test that you can do is basically to see if the patient has got any shifting dullness. So what we would do is because fluid will percuss dull, we would go over the umbilical area, percuss until we hear an area where it is turning from resonant to dull. You then can either make a mark there, or you can hold your hand in that area and ask the patient to turn on the opposite side. Can you just turn on the left-hand side, please? Wait a few seconds. This will help for the fluid to basically drain to the lower parts with gravity. And over that area that was dull initially, you can percuss again. And if it is now resonant, you can determine that the patient has got shifting dullness. So the fluid actually moved downwards, and you are now percussing over a resonant area. The next step basically would be in a patient who's got a large area of resonant or hyperresonant percussion over the left upper quadrant part, or even the central part of the abdomen. You need to do a test to determine if the patient has got either a gastric outlet obstruction or duodenal obstruction, which will then cause a large stomach lying in that area. Now what we do is basically to ask the patient to fully relax the abdomen. You can take the abdomen with both hands and then just from side to side, shift it from side to side like this. And if he hears splashing sounds inside, that would mean the patient has got what we call a percussion splash. That can also be listened to on with a stethoscope while you're doing your basically your auscultation. The last step would then be your auscultation. So what you would do is to listen in all these quadrants that we've identified now, to listen for bowel sounds. Normal bowel sounds will mean that the patient has got soft gurgling bowel sounds every few seconds. If you listen for around about 30 seconds over a certain area and you do not find any bowel sounds, it might be that there's a component of ileus that is happening in the patient's abdomen. If the patient has got a mechanical obstruction, what would happen is that the bowel sounds would be more higher pitched, and we would talk about tingling bowel sounds. So you would hear very high and an increased intensity in the sounds as you listen to it over the abdominal cavity. Always remember that to end off your abdominal examination, on auscultation, you also need to auscultate over your larger vessels. In other words, your aorta, as well as over the renal arteries on the back, just below the ribcage on either side. And then to conclude, basically, your abdominal examination is to always go and feel in your inguinal areas for any masses that's protruding in those areas. You can ask your patient to aid in this examination. You ask the patient to cough for you. Can you cough for me, please? Okay. Always compare the other side as well, and remember to examine the other side as well. Cough for me, please. Okay. If you don't have an expansile cough impulse in that area, it might be that the patient has got normal inguinal areas without any evidence of a hernia there. And then also remember to do a rectal examination as part of your abdominal examination to detect any enlarged prostate or any tumor that's situated in the pouch of your pelvis. On auscultation of the abdomen, you need first of all to listen for bowel sounds. In a patient with normal bowel sounds, you will hear soft gurgling sounds that will appear every few seconds in the patient's abdomen. So what you would do is to listen over the 9 quadrants that we already discussed, on each quadrant listening for the presence of bowel sounds. If you do not hear any bowel sounds within a 30-second period, it might be that the patient is experiencing something like an ileus. Bowel sounds in a patient that has got a mechanical obstruction would be high-pitched and what we would call tingling bowel sounds of increased nature, as well as the volume that you would hear. remember to always keep on listening if you do not hear any bowel sounds for at least 30 seconds to determine if eyelash is present. The next important step in auscultation is then to listen for any bruit in the abdomen over the major vessels as well as over your renal arteries. There are two ways to listen to bruit over the renal arteries. The first is from the anterior aspect of the patient's abdomen, which might be a bit difficult because of overlying bowel and interference with the bowel sounds with the actual bruit that you might hear on the renal arteries. So first of all, you listen in the epigastrium over the aorta to see if you can detect any aortic stenosis there. Then on the level of the umbilicus, as well as over the iliac vessels in the left and right iliac fossas on either side. Your renal arteries are located just below the edges of the ribs on either side, so you can listen over those areas from anterior as well. But bowel sounds might make it difficult. In that case, you can also ask your patient to sit up and then listen on the back so that you can have a closer area to the renal arteries where you can then maybe hear any bruit. Just sit up for me. That's one like this. You would basically go to just below the edge of the rib and listen in the paravertebral space on either side. Okay, that's fine. And that would conclude the auscultation part of your abdominal examination.